Good evening to everyone. Thank you so much for joining us this evening. This is the third speaker in our series, The Cranial Connection, and we're delighted to have Dr. Peter Bishop with us today. He's a dentist who completed his training in 1973 and then worked for several years on the NHS before moving into private practice. He's focused ever since then on occlusal support and amalgam-free holistic dentistry. He's been working with chiropractors since the 1980s and with Dr. Ian Smith, who you may know from our last two webinars on the craniocervical system and instability for over 20 years. So I'll leave everything else to Dr. Bishop. Very much looking forward to it. Dr. Bishop, if you speak for about 45 minutes, we'll have 15 minutes at the end for questions, and there are Q&A and chat buttons at the bottom. Everyone, if you'd like to leave your questions in those, we'll go through as many of them as we can at the end. Thank you.
Okay, I'll do my best. How is that?
That's tremendous. Thank you.
That's on? Okay, my thanks to Gillian and the Academy of Nutritional Medicine for giving me this opportunity to explain my role as a functional dentist in the treatment of dental occlusion, particularly as a part of the treatment protocol for atlas-orthogonal patients and for those with the condition of Craniocervical junction syndrome, Craniocervical Instability and Ehlers Danlos Syndrome. The approach is no different to that which I've always practiced. It's just more demanding and with very poorly patients. The screenshot here was from Ian's presentation last week and places me in this hierarchy of the triage protocol in the management of his complicated craniocervical patients. And when I asked him to explain why he's referring patients particularly, his answer was that dental occlusal interferences and dysfunction will cause repetitive strains in the jaw, skull, and upper neck, which affect body posture and movement, blood flow to and from the brain, movement of cerebrospinal fluid around the brain and the spine. And as he succinctly put in his lecture last week, it's like a hand in a glove, the relationship of the bite to the craniocervical junction. Our study group is attempting to establish a conservative treatment protocol that avoids going straight to surgery and investigates all underlying causes which can be modified and corrected, the bite being an obvious one. This slide is from Jeff Okerson's excellent book on the management of TMJ disorders and occlusion, and shows the interrelationship of the muscle groups and reciprocal effects of one group on another. I won't dwell on the detailed neuroanatomy, which is well beyond my capabilities, other than to say this is a very well innovated and protected system that is also, fortunately, very adaptable. And I just wonder if I can get this. The most common causes of muscle pain in the head and neck is the displacement of the mandible dictated by the maximum fit of the teeth, intercuspation of the teeth. And there'll always be an effect on the jaw joint. The normal activities of the stomatic gnathic system will show, again from Okerson's book, will show a frequency of contact of teeth of less than 5 minutes in normal function. exhibiting a force of about 17,000 pounds sex per day. This is a well-protected, and the forces are vertically down the teeth, and normally will not be a problem, such a problem for the craniocervical area unless there is a massive displacement of the teeth. It's the abnormal activities in parafunction which are the most problematic, and these forces are over 3 times greater and in a harmful transverse direction, which is, and those figures come from this studied by Gibbs and Mahan, and they will show in forces of, and that's with a small group of patients with a full dentition without any displaced teeth, were showing forces of 57,000 pounds sex per day, which is over 3 times greater in parafunctional forces. So what is an ideal dental occlusion? We want 2 full arches of teeth in harmony with the muscles of the head and neck, and no proprioceptive reaction, no changes which will affect the muscles, and require no adaptive changes. This is a class 1. This was a post-orthodontic treatment, one of my old cases, which we often treat these patients with orthopedics first to get a good arch shape and avoid any possible extractions within the arch, and create an ideal arch form, and then create a good occlusion which hardly ever needs any adjustment. So that's the possibility that can be achieved. The blue marks indicate where, using blue ink, the lateral movements of the jaw are reflected in contact on the front teeth, and that's an important factor with the bite, so that when the jaw slides forwards and sideways, the front teeth engage and the back teeth are slightly apart. That when the back teeth remain in contact in lateral movements is when you get into trouble and you start getting strong proprioceptive reactions from the muscles. The classification of class 1 comes from the mesiobuccal cusp lining up with the midline groove on the lower first molar, and the relationship of the canine teeth. But we can't always achieve a class 1 relationship for every patient, but there are different ramifications which I'll come to later on. So how do we get to assess the occlusal function? We'll have a referral letter to start with, which will give us a good indicator of the problems from Ian's chiropractic standpoint, and usually a history to go with it. We'll then establish a contact by email. We'll send a raft of 5 or 6 questionnaires out with that, which includes a medical history. I'm not going to go through each questionnaire in detail, except it's here online if anyone wants to refer back to it, and you're welcome to use it if you want to. But this dysfunction screening will give us a scoring of mild, moderate, or severe on these quite common signs and symptoms of craniomandibular dysfunction. And this will be a useful reference in the future for comparing when a patient further down the line is hopefully having some successful treatment. Further on in the questionnaire, it's interesting to know what medication the patient is on, what the injury history, which is quite a common feature of a lot of these patients, and particularly whiplash, which Francis Smith referred to. recent dental treatments, bite changes. Tinnitus is worth a mention in its own right. There has been established a link between the middle ear malleus and the disc of the jaw joint, which is the discomallear ligament or Pinto's ligament, which is a very strong possibility in some patients. And in fact, it's been found in as many as in one group that were dissected in detail, as much as 80% of them had this ligament present, which could be a strong contender for a routine, and why there's a strong association between tinnitus and jaw joint problems, because the lateral pterygoid muscle, which attaches to the disc of the jaw joint, is linked directly through then to the middle ear. These high-pitched whining and sort of sounds and whooshing noises that people often complain about. And anecdotally, we find that sometimes, not predictably always, but a lot of times these tinnitus problems will at least be modulated or moderated. And then we want to know how debilitating the condition is. The pain history and charting is an important factor, and so you can scribble on here lots of areas of pain, and sometimes these are covered in red ink, and patients have had a horrible time and been going on for years and years, and it's a good kind of graphic indicator of where we're starting from. The dental history and symptoms, obviously we want to know all of these points as well regarding the teeth themselves. And I've also recently added the sated sleep questionnaire to my list of email attachments, and it's because I know how important sleep is as a foundation of health, and it's important also to find out what is the satisfaction, alertness, timing, efficiency, and duration. I must say myself, I didn't score, I think I got about a 4 out of 10 for that one. So there's some work to do there. But Matthew Walker's book, Why We Sleep, is a big recommendation from me, which came from a recommendation from the MedChi lecture we went to. So sleep is important. It's a foundation to good health, 7 to 8 hours a night. Ideally, and unbroken. But as you get older, that's very unlikely. And I think probably one of the stressor reasons why people cycle into these tooth grinding, parafunction kind of habits is because, you know, when your bladder is full at 1 in the morning, and you will start writhing around and come slightly out of REM sleep. Maybe it's between REM and non-REM sleep. Cycling between the two is when these parafunctional tooth grinding, bruxing episodes take place. And this is certainly, as we know, anyone who goes to bed with a problem on their mind will have a less than satisfactory night's sleep, because stress, and particularly if you're one of the unfortunate patients who've been referred with a severe pain problem, this is it's going to be made worse by a poor night's sleep as well, and you're going to make you grind your teeth more. The teeth naturally clench and grind more when you are in pain, as an unfortunate byproduct. So having established all the history and the symptoms, I'm now going to meet the patient and find out what this is the patient we showed earlier, the class 1, this patient's in for a good time. Generally, they're going to have a fairly satisfactory, stress-free time. Class 2 patients are going to have a little bit more difficulty contending with a bit of their lower jaw is smaller than their upper jaw, and that's a residual problem that starts. All infants start with that kind of format, and I believe if a number of those can be encouraged to grow, if you establish good orthopedic treatment at the right age, and I think this should be accessed from the age of 6. You should be looking carefully at how the second teeth are coming in. If there isn't room for the upper incisors to come into place in line, then you haven't got enough upper width in the arch, and you're not get that nice Roman arch form. And you have a narrow arch form, then that's going to inhibit the growth of the lower jaw, and it's going to remain in the class 2 position. And even though this particular lady had all the right sort of treatment, it just wasn't completely effective. This class 3 is a little bit more of a difficult issue. This is kind of overgrowth or a strong growth, like the Habsburg jaw. It's a class 3 jaw. It's very strong. The conventional orthodontic view used to be let the thing grow and then do surgery, which I'm not particularly a fan of, and I would try and I again would exhort anyone to try and treat that before it ever gets out of control, rather than let it happen. And once you've let it go past the age of 12, it's too late. That's back to my orthopedic days anyway. So I'm going to focus on the main event now. We're going to continue. This patient, Charlie, I spoke to my daughter, Charlotte, who does a lot of orthopedic treatment, and she reckons this was one of her patients that I borrowed the slide from. Had quite a severe gum problem, and they're being quite well maintained actually, but there's been a lot of bone loss and struggling to anyway. It's a difficult problem. Gum problems can manifest and be never as obvious as this, and you can just start to, if you pass a probe down the side of the gum, you can just detect detachment of the gum from the tooth. These are early signs which need to be noted, and they are possibly the beginnings of a bone stress lesion, which can be exacerbated by the bite. So if the muscles are working against a tooth, it's going to make the bone recede and the gum condition work. Periodontists universally recognize now that they get a better periodontal surgical result when they recognize the forces of the bite and treat the bite in harmony with treating the gum condition. Wear and tear on the teeth is, again, an obvious sign on the surfaces of the teeth. And we're interested in, this was my mouth when I was 33 years old. And I had a problem which I'm going to illuminate a little bit further on in my talk, but this, I put this one in, it's an old slide, an old digital picture of a slide, but it's you can see how there is gum recession there, which is often called, and slight dishing of the enamel and loss of tooth structure. These are called abfraction lesions. They relate directly, as my good friend and mentor Michael Kader showed in a presentation, an absolute 100% relationship between the bite forces and the abfraction lesions. And where we were always taught it related to toothbrushing, he would always say, how do you get site-selective toothbrush abrasion? How do you brush this one harder than this one and not get an abfracture there? So it's a compelling argument, which continues as a slightly controversial subject, but I think it's a combination thing. The forces of the bite cause a weakening of the crystalline structure around the neck of the teeth, and then you brush away the effects of that. And interestingly, similar types of lesions are seen in the middle of the shin bone of infantrymen. After prolonged marching, they will get slight dishing out. This abfraction lesions will occur on their long bones of the shins. So it's a good argument for being a stress-related lesion. Restorations, we're not going to have time to even begin to talk about the whys and wherefores, but this kind of restoration, amalgam, should be just a thing of the past. It's so outmoded. And when you get large fillings like this, with a bite force effective on that tooth, it's going to crack the tooth 90% of the time. Of all of the large amalgams that I used to remove, very carefully, I'd have to say, under rubber dam and lots of water and suction, and very carefully, and even more carefully these days in the case of COVID. I'm quite glad I'm not doing it with a respirator on and everything, but those kind of restorations had a lot of damage underneath them, and those cracked teeth were, we effectively glued them back together by putting composite resins in. Missing teeth, obviously, significant. This this lady had a number of implants placed, which were very technically very nice, and was a very complicated case that gave a very nice result. But as I'll show later, there was a poor functional occlusion, which didn't leave her with a very happy bite. Wisdom teeth are worth a special mention as well, because they can remain in plain sight. You can't even see, looking at the patient biting normally, they've got a problem wisdom tooth until they protrude their jaw, and that becomes a point about which the muscles can feel and push and squeeze and rub and rock on that, and they can be making merry on that all night long and create havoc. And this particular lady had lots of functional issues, I seem to remember, and she was a keen runner and was finding problems which her chiropractor probably would have been, if she wasn't a GP, would have been fixing, but they probably didn't have a chiropractor. But this is, anyway, so we're going on to further look at the muscles and the TMJ. These are all of the muscles of the head and neck, which we're going to look at in sequence and note any tenderness or lack of tenderness, and going to feel the jaw joints as well. The outside of the jaw joints, the lateral capsule, the back of the jaw joint is felt through the ear meatus, external auditory meatus, the ear hole. By putting a finger in the ear, you can feel when the jaw opens and closes. If that's tender, retrodiscal tissue is an elasticated tissue, but if it's inflamed, it will be very tender when you feel it through the ear. We note any changes to the opening and closing of the jaw, any deviation of movement, noises, clicks, crepitus. Range of motion is a standard test for all joints, and with this particular example here, it's 23 millimeters, which is significantly poor. The temporomandibular joint is a compound joint. It's two joints in one, and the top part of the joint, which articulates against the skull, between the ball and socket, there is a fibrous disc which has no innervation at all. The top part is a smooth sliding joint, and the bottom part is the rotating joint. So this is probably a bit of muscular splinting, and it's inhibiting the opening into, and is stopping the jaw opening as far as being able to slide, so that the muscles are splinting very hard. So it's a cry for help and something's wrong. A word of praise for Janet Travella and David Simon's book, which was, I'm sure a lot of you who are therapists are familiar with this work, and it was one of the first really good books about muscles, and she did a clever thing in injecting all of the muscles of the body. And some of them, the mind boggles how she would even get to some of the muscles, but she injected them with saline solution where the X marks on the pictures here, and would note where the pain was felt by the patient or the subject or the impecunious medical student who's getting paid for having his muscles injected with saline solution. But this is a good marker of myofascial pain, and a particular note for dentists how the temporalis muscle, which is the muscle that attaches to the coronoid process, the front part of the jaw joint, through the cheekbone and attaches to the side of the skull. This is the main one of the two main elevator muscles, they're called. If you inject the front part of it, it's going to make the front teeth painful, and so on with the other marks. On the other elevator muscle, the masseter, injecting the superficial masseter with saline solution, it will elicit pain along all of the mandibular teeth. And I had personal experience of that before I knew anything about bites or knew anything about occlusion, and pre-publication of this wonderful book. I remember treating a patient who came in with a toothache on a lower premolar, and could see nothing at all wrong with the tooth, but he desperate for me to do something to the tooth because he was in pain, and I'm convinced now, in looking back on it, that he had a myofascial pain coming from that muscle, and when you push on those sore points, it will cause the tooth to ache. Back to the temporomandibular joint, which is our special joint. This is the particular interest with the lower jaw is you've got one bone with a joint at each end of it, and this myriad of muscles that will control and fine tune the movements of the jaw. The lateral pterygoid muscle has two parts. The superior belly, it just moves the disc, this fibrous disc that sits between the base of the skull. And as I said, it was a compound joint. This bit is the sliding bit, and this bit is the rotating bit. So we need to, when we open, we'll rotate, and it won't be active at all unless there's an interference in the teeth, in which case the muscle will spring into action and slightly rejig the position of the jaw. So this muscle gets sore if there are occlusal interferences, if there are bite interferences that stop the condyle going into its seated position, which is superiorly and medially. And we know this anatomically when you dissect these cases. The disc has a kind of biconcave construction that's slightly thinner and non-innervated, so that its natural position is seated fully up and squeeze. The muscles will pull it up in that direction. So that's a special interest to anyone concerned with bites, is the lateral pterygoid muscle. More interesting for Ian's line of work is all of the neck muscles that are involved with the infrahyoid group of muscles. And I'll mention a case later, which when we challenged the hyoid bone here, it created a fitting attack in one of Ian's patients. But it's also worth mentioning in passing the scalene muscles, which is a kind of a bit of a design fault, because the whole brachial plexus passes between the scalene muscles. And I know from experience from a patient who was destined for surgery for carpal tunnel, and she, I mean, we'd done all her original replacements of amalgams. This was my work with porcelain crowns and occlusal fillings. But she'd had in her youth had extractions done on the bicuspids, and she had a high-powered IT job and was probably fairly A-type person, and she ground her teeth probably regularly every night to get them nice and flat and smooth. But it's slightly ineffective even with equilibration. We couldn't get those to quite meet in lateral function, so we fitted her with a Tanner appliance, and lo and behold, I'm pleased to say she didn't need the carpal tunnel syndrome surgery and has avoided it still by fitting a Tanner appliance. This was my case, which was a case of establishing empathy, if ever there was one. Although it was in my early days of probably I'd been to the Pankey Institute in 1981. I was learning all about bites, and I invited Michael Kader over to my practice and to run a course for me in Bristol. And he did this. I told him about this, neck problem, this intermittent torticollis I had, and he took a look at my bite and did some bite marks on it. You can see a big blue mark there with lateral forces of grinding. You see that upper cusp grinding out there every night, and the consequent across arch, that lipping and that key and lock faceting, where those teeth are working against each other, and how those teeth are rocking, how the opening and closing on that fulcrum. And that fulcrum was creating a click in the jaw joint on that side. And occasionally, I've been doing enough of it at night. I wake up in the morning and I couldn't move my neck. I was like this, sort of wry neck, torticollis. And it's there is a known. I haven't had it ever since the equilibration, I'm pleased to say. Well, we get to the hub of the matter now, is study models mounted in centric relation on an anatomical articulator. What we're interested in seeing is when the jaw joints are fully seated in the sockets without any muscle interaction, irrespective of the tooth position. So we need to have some accurate models in alginates in metal trays, poured up immediately. We need a centric relation bite, which is shown here. I'm gently holding the chin between my finger and thumb, and the three fingers at the back here are pushing up on the back of the jaw to push it. I'll just go back to that one just to show you what the fingers are doing then. Thumb is pushing down and those three fingers are pushing up to seat the jaw fully in the socket. This is superiorly and medially braced. Now, different if patients are coming to you and they're quite poorly, you may not be able to achieve a perfect centric relation. It should never stop you starting, because the Tanner appliance, where we'll get to eventually, is going to allow you to work towards that position. But you've got to try and take the muscles out of the equation, have them nice and relaxed, and rotating gently on that hinge movement without any muscle resistance. Centric relation is defined as the relationship of the mandible to the maxilla when the properly aligned disc assembly are in the most superior position against the eminentia, irrespective of tooth position or vertical dimension. So take the muscles out of the picture, take the teeth out of the picture, put the joint in the right position, and just see where the teeth are in that relationship. So to transfer that information across, we need a face bow to transfer the model of the upper jaw. So these are the jaw joints, and this is the upper jaw. And then we're going to mount the lower model to the upper model to the centric relation bite. And then we'll see where we end up on this articulated set of models. And that allows us to make on the model, we put a foil base on the lower model, and using this triad trans sheet, which is a colorless light cured acrylic. They used to do it in very convenient ropes, which I used to buy by the box for, but for some reason, best known to themselves, they stopped making it. And we can only get these sheets now, which you have to fold into 3, so you don't get any air inclusions, but it's the same material essentially. And important thing is it sets to a hard plastic, so we want to balance this. We're balancing this, adjusting this to be a new bite surface on the lower jaw. It becomes a clip-on perfect bite when it's adjusted. All of the back teeth are touching evenly. It's like balancing an 8-leg table. You've got to sort of keep adjusting it as the muscles are readjusting and moving. We take an hour to fit these appliances, and then they have to be adjusted again the next day because there's been a lot of movement, and then they have to be adjusted again after a couple of weeks, because they're a permissive appliance that's allowing the jaw muscles to relax, allowing the system to assume a relaxed, comfortable position in harmony with the craniomandibular system, the stomatognatic system. So it provides an ideal occlusion in harmony with the muscles. And empirically ask the question, which I think is important, how would having a perfect bite affect you? And it answers the question by becoming a diagnostic and a treatment appliance, which can be used long-term. Provides an indirect, reversible method of altering the occlusion until a correct TMJ condyle position is determined and confirmed. Allows healing and tissue repair of joints and muscles and ligaments. Allows adjunctive therapies to be started, i.e. atlas-orthogonal treatment. Ian can get on with his stuff, and while the patient's getting better, helps in the understanding of nocturnal bruxing. I explain it, it's like a tachograph for the teeth. As the patient's grinding on it, they'll create grooves in it and notches in it, and it gives you a good understanding of how much activity is still taking place on the teeth. Applies immediate relief to a distressed dentition and periodontium, and can be used for orthodontic retention pre-equilibration. What we use to adjust the appliance are these papers, slightly thick. I'm sitting behind the patient's head here, holding the papers in a miller's forceps and holding them between the teeth and getting them to mark exclusions, which means moving the jaw forwards and backwards and sideways and clenching, and then just tap on the teeth just to make a mark where the red marks are. And there you have your clip-on perfect bite, which you take it out and you back to where you were. It's a reversible. Occasionally, and this has only happened to me once, I fitted a tanner appliance and Amy here reacted very badly to it and came in the next day wearing a neck brace. She was that class 2 case I showed you earlier, but we resorted to giving her an anterior deprogrammer. It's a good emergency appliance if you were stuck in a hole and the patient comes in with a serious jaw problem and you've got 15 minutes to try and get them out of a jam. You can do that. Put some cotton wool rolls between the teeth and let the jaw relax. If you do that, the jaw joints are going to naturally seek a home position if none of the teeth are touching. The jaw joints are lubricated with synovial fluid, which is the slipperiest substance known to man, and it will slide up into position if you take the muscles out of the picture. Then you just put some triad between the teeth and set it with a light, forms of hard plastic. Someone tried manufacturing, what was it called, an NTI appliance, just on the upper central incisors. Didn't get great results. And I mean, these anterior deprogrammers are as old as the hills and been used by my predecessors for donkey's years. But we only use them temporarily because they only cover some of the teeth, and therefore the back teeth could erupt and could therefore cause an issue later down the line. So we would then polish that to a really fine polish, but we've got firing 2 tram lines as the lateral pterygoids firing in synchrony forwards, and the lateral excursions as the canines slide out and smoothly and in a shallow incline take the lateral forces of the jaw. So there's no back tooth contact. That shuts down the muscle system. The elevator muscles just shut down, and any muscle problems from the elevator muscles will then be removed. I'll show you Roy's case now. He was referred by Ian. He had his 15-year history of trigeminal neuralgia and had been taking a maximum dose of Tegretol, which is scary in itself. This was his acquired bite. He had a cross bite at the front. This is his centric relation occlusion record. We made Roy an anterior deprogrammer because when I touched his temporalis muscle, he would go into paroxysms of pain. So we had to treat him with kid gloves to start with. So I didn't think I was going to be able to even fit a tanner appliance. So as a precaution, I made him an anterior deprogrammer just to quieten things down a bit so that we could then get his jaw into a more manageable position, jaw muscles into a more manageable position. This was his bite from the inside, the centric relation bite. You can see it's chaotic, to say the least, and how he was managing to work around the centric relation interference on his upper third molar and slight contact there. That was his centric relation occlusion. And then he slammed down forwards onto that crossbite, and the temporalis up on this side was objecting big time. So we fitted that December 2019. This is a tanner appliance that he ended up with, and he's now not taking any medication and is pain-free and gets an occasional tingle, which gives him a heads up of when he's likely to be needing another adjustment. Might need some dentistry there, Roy, with those amalgams, but that's another issue. Emma Jane, again referred by in 2018, long history of headaches since her teens, had bicuspid extractions again. This to a layperson may look, well, they look nice and straight, nice teeth. All the muscles are tender. She could open us just a little bit into translation. She was rotating 3 centimeters and the joint was moving 6 millimeters further on. Low energy and tinnitus. This is her chaotic centric occlusion bite, and in lateral movements, she was engaging on the back teeth and the front teeth couldn't engage, which is the reverse of what you want. When the jaw swings to one way or the other, the front teeth should be coming together and the back teeth should be apart. If that doesn't happen, the elevator muscles stay switched on and they will stay active and hyperactive and become problematic. So the Tanner appliance gives her that facility, and energy increase, headaches decrease, no migraines now. And she has a nice smooth, shallow. This smoothness and shallowness is important. If you're going to put a piece of plastic in the mouth, it's got to be conducive to muscular harmony and not in any way create any roughness or any kind of discrepancy in the bite. So it's got to be even and it's got to be smooth. And it's got to have a mutual protection, the front teeth taking the lateral pressure of all movements and the back teeth taking all the vertical pressure. This was the case I showed in this was referred to Ian by her clinic in Germany. She was having treatment, unfortunately, for Lyme disease. And she's undergoing all kinds of concerns about whether she should be worried about having metal implants in there and metal fillings and metal crowns and root fillings, which are, I know, as far as the Klinghardt protocols are all potential areas of harboring the Borrelia spirochetes. So it's anyway, our initial concerns are to give Nicole a good bite. So these are how the teeth looked on the inside. Poor centric relation occlusion, and she was getting daily migraines, which were classically behind the eye. So it indicated to me it's probably the lateral pterygoid muscle, and the bite on the close analysis using the red ink show that these teeth are touching on slopes in centric relation, and but probably what compounds it and makes it worse is that in lateral movements, again, like Emma Jane, when she goes into lateral excursions, without the Tanner appliance in, the front teeth are engaging, and that is a big red rag. And I hopefully this will clear some of the brain fog and help. It's already diminished the migraine headaches and given her more energy. This case is another. I'm getting quite low on time now. So, 20-year history of head and neck, craniocervical junction syndrome. She had an inappropriate neck manipulation and went to see Ian. He did some wonderful treatment for her and got her out of trouble for 10 months. But so there's still something not quite right here. And when we look at her X-ray, you can see at the back here, the wisdom teeth are over erupting. One's been troublesome down here on its side, and these X-rays are taken with the jaw protruding. So this is in a protruded position. When we took study models of mouth, the only teeth she bites on him when the jaw is trying to go to fit in the socket, centric relation occlusion, are the third molars. And there is you can probably see it there, just a wear facet on them where they then slide down that every time swallow. That's where the jaw is trying to go. As it takes me about 2 hours to make, because we tend to get these patients from long distance or overseas, and we'll try and do the impressions midday, do all the model work, and fit the appliance in the afternoon, and then readjust it the next day, so they have an overnight stay in Bath. But because my colleague in the surgery next door had a spare moment, I persuaded him to remove the upper offending wisdom teeth while we were making the appliance. So we went home with a Tanner appliance, which was, I think we're getting somewhere with the craniocervical junction problems. That was before the extractions, and that was a month later. Lastly, I better make this the last one. Holly is, she's got the full works, I think. Holly's EDS, CCJ, CCI, IBS, POTS, and referred by her neurosurgeon to get an atlas-orthogonal opinion. She is a 4 bicuspid extraction case again, which shows a very poor centric relation occlusion and 10 years severe pain history since dislocating a shoulder. She came with a warning that she was going to probably have a fit during the examination. Well, she pretty well did when I touched the hyoid bone. I haven't seen Holly for a follow-up, but she's had this Tanner appliance fitted and probably needs adjustment. Very lastly, squeeze in this case of there who's just been, she's just had fixation done in America but she was referred by Professor Smith because she was getting an acute problem with this. It's a bit blurry, I'm afraid, the picture, but there's a slope here which articulates with a slope here, which this is the centric relation position with the sleep appliance, and it makes the jaw protrude in a forward position, which is the rationale is to open the throat to enable breathing and improve sleeping. But it's probably not recommended with Ehlers Danlos Syndrome patients because it will send them into a flat spin. And this was, there's centric relation occlusion. And you can see from the evidence, again, the wear on the teeth, flattening off, and a long history of tooth bruxing. And this is the appliance, which, interestingly, her dad was adjusting for her by a remote control. So he did quite a good job, actually. And this is the appliance in place and movements on smooth movements of the jaw laterally and forward. So in summary, centric relation mounted models are an essential record to understanding dental occlusal function. Occlusal parafunction or tooth grinding can cause upper cervical dysfunction as well as craniomandibular dysfunction and affect sleep and should be recognized and treated. A healthy mouth is essential for a healthy patient. My formula to achieve and maintain a healthy mouth would be avoid refined sugar, have good oral hygiene, get your teeth checked or get your children's teeth checked between the ages of 8 and 12. get them to develop properly and avoid trauma, RTAs and horses. If you haven't managed any of these, get your bite fixed with a Tanner appliance and equilibration. See a good AO practitioner at the end.
Oh, thank you very, very much. What is that at the end there?
That's the sun.
Oh, really? Thank you. Well, that was
I haven't
fascinating.
seen for a while.
No, it's an interesting perspective. Well, we've had lots and lots of questions come in, so I'll start firing away. I'll try and gather them together in groups, quite a few about sleep to start with. So how does the jaw and bite affect sleep apnea?
Sleep apnea.
Yeah, that was the question.
Well, it affects the jaw position. It's lack of space behind the tongue that's the issue, and there are two treatments recognized for sleep apnea. One is CPAP, which is that noisy thing that you have to have oxygen cylinder by your bed, making a level of a row and trying to stop you go to sleep. The other is the type of appliance I showed on there, which is one which will allow the jaw to protrude and open the airway space. So it's not the teeth per se, although loss of vertical dimension and extreme wear and loss of teeth can exacerbate the problem. They say one of the biggest problems probably is obesity. So I suppose teeth are only indirectly involved with that.
Thank you. This, of course, relates to that. Is centric relation the opposite of mandibular advancement for sleep apnea?
Centric relation is, yes, centric relation is a border position. It's the position where the joint is seated in the socket. A mandibular advancement is literally that, is protruding the jaw.
Okay, thank you. Thank you. And when the jaw luxates a lot, is this Tanner device helpful?
Luxates, dislocates, you mean, sort of?
Yes, I suppose that's what is meant to hear.
Yeah, that's an interesting question. I think anything that implies a severe laxity of ligaments, but it's one of those things I think you'd have to see the specifics to understand and answer that question. Mm-hmm. But there's no direct cause and effect.
Thank you. I'll go to the Q&A for now because the questions have come in on both tabs. This is a complex one here. Could you please comment on your experience of the role of the small segmental muscles, OA, C12 in particular, which have a privileged shared innervation with CNX, which I think is the 10th cranial nerve, and their contributing role in locking or creating dysfunction in the TMJ?
Wow. I'm not sure I completely understand that question.
Well, I'll send that in to you. You've kindly said that we can send in questions to you. We've also had a few that are very patient specific, and we'll send them in to you. And you've kindly said you'll give us an email afterwards, which will then enable people to contact you about them. Now, that was a long question to read and immediately be able to take in for me too. What do you think of Invisalign treatment?
Can be effective. It's limited in its scope. You can tilt teeth and move. It's like playing sort of dental checkers. You can move one tooth at a time, a little bit, and through lots of different elasticated aligners, as they're called. So yes, it has place, but it's probably not as effective as traditional orthodontics in moving teeth.
Thank you. Is it possible to expand the upper maxillary arch and palate in individuals who no longer have any molars in the upper lower in the lower mandibular arch.
Is it possible to expand
The upper maxillary arch and palate.
if you haven't got any molars?
If people no longer have any molars and no protheses or implants in the lower mandibular arch. Does that work, or do you first have to?
Well, you have to have teeth to be able to expand, I think, yes, because if you can't use implants for expansion. If you put an implant in the jaw, it's a fixture that becomes an anchorage point. In fact, it's used for anchorage. That will stay fixed in that point. That's one of the problems which I didn't really have time to highlight, but one of the problems with implants is that they don't have a ligament around them, no kind of give and take, so they are fixed and become an anchorage point, and everything else will be subservient to them.
Right, thank you. What denture materials are the least toxic in your experience and opinion?
What denture materials?
That's the question here, are the least toxic, yeah. Or is that very patient dependent? Do you like patients to test, or is this not a field that you get involved in at all?
It's not a field that I currently get involved with, no. I've never particularly thought about that. I don't know whether there's any choice other than the current plastics which are used, which they do say that, I know Hal Huggins used to say that the pink material certainly in the old acrylics used to have mercury content. So he used to make acrylic dentures with a clear acrylic for that reason. So if you have someone who's particularly sensitive, or you're particularly nervous about anything with mercury, as we tend to be, then that's probably a good thing to avoid.
Right. Bruxism has been found to be more common in patients with EDS, that's Ehlers Danlos Syndrome, compared to the general population. Do you think
that? Yeah.
Do you think that this is as a result of hypermobility or poor proprioception?
Hypermobility will certainly have a large bearing on that, yeah, because that creates a laxity in the joints.
Right, and do you think that this precedes associated pain in other regions in cases like this?
Does it precede it? I don't know. I don't know the answer to that.
Okay, yeah. Again, probably very patient specific. There's a question here. My 15-year-old son with CCI has been a mouth breather for years, and now his lower jaw is sitting way back. And when he bites, it's only his back teeth that touch. He has TMJ issues. Is there a lot that can be done at this age, at 15?
Yeah, certainly it's worth considering looking at. There's still, I mean, I think the main windows of treatment orthopedically are the whole system is, the jaw joints aren't really formed until that age, but they are now in the juvenile form formed now at age 15. So you're kind of starting from a mature adult, a maturing adult's position, which is more difficult than if you start at the age of 10, obviously, when the whole system is plastic and you can influence the changes in the jaw with applying forces that will cause osteoblastic change. So it's again, it's a bit of a specific question that
Yeah,
you have to kind of look at the circumstances.
Exactly. I think we'll suggest that she perhaps writes into you to get any further advice on that. This is an interesting one relating to infection, which you did mention in your talk. Can Borrelia bacteria reside in root canals after treatment? And if so, is there a way of eliminating the bacteria?
Well, if you listen to the Klinghardt protocols, then the only way is to extract a tooth and then to curette the socket. I'm not an expert on that field, and it's a bit beyond my provenance, but that would be one for Dr. Klinghardt.
Okay, thank you. Roughly how many visits are required, and what is the rough cost of the Tanner appliance?
Okay. How many visits are involved? Well, as I intimated, the first day is a sort of an hour, 2 1-hour appointments with a gap of about 3 hours while we do the model work and make the appliance, and then another half an hour to an hour adjusting it the next day, and then we'll adjust it again a couple of weeks later. My fee for making an appliance and doing the first adjustment is £1,400.
Okay, thank you very much. There are questions here relating to whether you do Zooms and so on, but I don't know. I mean, is it possible to do Zoom consultations for international patients? Just throw that one in because I have that from a few people here.
I'll have to think about that one.
It's probably rather hard, isn't it? Yeah. Last 1 or 2 questions because we are running over time here. When and how does a person use the Tanner device? I was going to ask that myself, whether they wear it all day or exactly when.
Initially, they do wear it all day because if you think about it, the moment they take it out, they've got their bite problem back again. But we then kind of encourage them to leave it out most of the time during the daytime if they can, but encourage them to become aware of what they're doing with their teeth. And as Henry Tanner himself said, it's not so much how the teeth bite, but what people do with their teeth that matters. And so if you can, by using a feedback system, we get people to set an alarm, for example, that goes off every hour. You can modify any habits that you have to clench and squeeze and grind your teeth during the daytime while you're sentient and awake. But at nighttime, you can't be on guard for that. And so we say it's mandatory at night, and wear it in the daytime when you're likely to clench or grind your teeth or be unaware, like working on a computer or doing Zoom lessons, I suppose, and things like that, and driving a car, that kind of thing.
Okay, thank you. Well, I'll just ask one more question that's come in a couple of times as well, which is, are dentures or implants better, would you say, for middle-aged patients?
Again, that's case specific, but I would always say there's that an implant is superior in the sense that it's fixed, and therefore the problem with any dentures is generally how much support there is on the teeth. If it's a partial denture and it can be supported entirely by the teeth, the gum underneath the denture will always resorb, the bone will resorb, whereas with an implant that would offer a secure, solid support, but it has to be treated in such a way that with the adjustment allowing for the fact that it's not going to have the flexibility that a natural tooth would have. But the implants are used very successfully underneath dentures, which is probably the best combination.
That's very interesting, thank you. Maybe just to finish up, because obviously everybody's fascinated by what you have been saying, and now they're asking, are there dentists who practice your kind of with your kind of specialism, for example, elsewhere in Europe, like in the Netherlands?
Oh gosh, I have no experience of them. I hope there are. In this country, there's an organisation called the British Society of Occlusal Studies, BSOS, that run a website that has dentists who've had some training, and so anyone, I mean, when I started out, I had to go to America to learn all this stuff, but now at least people have got the opportunity to learn it in the UK. So but obviously, and I know the Pankey Institute where I went to in Miami was had a large international alumnus. So I'm sure there were one or two Dutch dentists from that. It might be worth inquiring of the LD Pankey Institute alumnus or the American Equilibration Society alumnus, which would be would show at least show a body that shows dentists and members who have an interest in the subject.
Yes, thank you. Well, people are also asking whether they'll be able to access the recording. The recording will go up on our website, so you'll be able to listen to those names that he's just mentioned and take them down and do further investigation. It's always under events, and then once you click on events, you'll see past webinars, and we put these webinars from the Cranial Connection series down under that, and the slides as well, if we're allowed to use them. So thank you very much indeed, Dr. Bishop. That was absolutely fascinating and a lot of information for us to take in. So I think a lot of us will want to watch that again.
It was something interesting to do in lockdown.
Yes, definitely. And a lot more questions have come in that I wasn't able to ask. So I'll send in some of those to you, but obviously it would probably be best if people contact you direct on your website, which we'll put together with the recording on our website within a few days. Okay. So thank you very much, everybody who is with us here today as well, listening. And huge thanks once again, Dr. Bishop.
Welcome. Good night.
Bye-bye. Good night.
Bye.